بین‌المللی ارائه شده توسط آیما با شرکت دانشگاه آنکارا بیمارستان آنکارا سیتی و دانشگاه تهران بیمارستان مرکز طبی کودکان خوش آمدید. لطفاً میکروفون هاتون رو ببندید و سوالاتتون رو در قسمت چت مطرح کنید. در پایان برنامه دوربین خود را برای 1 دقیقه روشن بگذارید تا تیم اجرایی عکسی به یادگار بگیرن. تا دقایقی دیگر در خدمت شما هستیم.
Good morning, everyone, and again, welcome to the first International Joint Morning Report presented by AYMA, Aligned Young Medics Association. Again, many thanks to dear Professor John Polat and Ankara University of Health Sciences and Ankara City Hospital for joining us in this joint morning report. And also welcome all Turkish participants and also other participants from the other countries. Also, thanks a lot for the Iranian participants for joining to this nice event. First, I want to introduce the dear scientific manager, my dear professor, Dr. Keyvan Mirnia. I pass the microphone to the professor for welcoming all of you, and take it, please. We are with you.
Morning, everybody. I would like to thank first from my dear old friend and my great professor, Professor John Polat, for adjusting such a meeting. This is the first joint meeting of morning report between Tehran Medical University and Ankara Hospital Medicine. I would like to thank everybody that they are in this great meeting. This is the first time that we are doing such a work. Well, maybe we have some technical problems in this between this, and we would like to apologize first before everything. Again, I would like to thank everybody for this joint meeting, and you're welcome, everybody. Thank you.
Thanks a lot, dear Professor Mirnia. Dear Professor John Polat and the dear resident, Dr. Asli Gent, are you with us?
Yes, we are here. Good morning.
Thanks a lot. Good morning. I want to thank you especially for joining us this early in the morning, and many thanks for accepting the invitation. I hope you're doing well, and I pass the managing the Turkish panel to you, dear Professor John Polat. You can start the slides, share the slides, start the case presentation, and then talk with the panelists.
Okay, thank you. Good morning, everyone. Greetings from Ankara, Turkey, to all, and with warm regards. We would like to thank your kind invitation to Tehran Medical University, and we will present a case of newborn, and Dr. Aslı Genç will present. I will share my screen. Okay, can you see that?
Yes, it's okay. Thanks a lot. We are with you.
Okay, we are starting now. Dr. Aslı.
Dear professors and colleagues, good morning. I am Dr. Aslı Genç, Senior Pediatric Resident in Ankara City Hospital. It's great to participate in this meeting. I would like to present you a newborn case with fever. Our case is a 14 days old term newborn who was brought to the pediatric emergency room with fever, which started the same day to administration. There were no history of cough, rhinorrhea, diarrhea, or dehydration. We learned that he vomited once and it was not related with feeding. He was born at 3.2 kilograms at term to a gravity 2 parity 2 mother by a repeat C-section with an unremarkable pregnancy. At 36th hour of his life, he received a day-long phototherapy because of indirect hyperbilirubinemia. On the physical examination, he seemed alert with good activity. He was breastfed with 3.8 kilograms weighted. He appeared warm and jaundiced. His body temperature was 38 centigrade Celsius. His heart rate and blood pressure were normal. He had mild tachypnea with an oxygen saturation 100 in the room air. And there were no other significant findings in the physical examination. So we did a full septic workup to our well-appearing febrile newborn. The full blood count was normal. The seroactive protein and interleukin-6 levels were high. And we performed a urine analysis with a urinary catheter, and it showed a remarkable pyuria with 3 positive leukosterols and a negative nitrate level. So we admitted our patient to the neonatal intensive care unit. And as a part of the septic workup and to rule out urosepsis, we did a lumbar puncture. The glucose and protein levels in the cerebrospinal fluid were normal. There were no cells in the smear and the culture was negative. And the culture in urine analysis showed us an ESBL positive 100,000 colonies of Escherichia coli. The antibiogram showed us an ampicillin resistancy. So we rearranged our antibiotics to amikacin and cefotaxime. We started IV therapy with IV hydration. We performed a chest X-ray, a COVID PCR test, a fast respiratory tract panel, a blood culture, and a renal ultrasonography. Our patient's chest X-ray seemed normal. The COVID PCR test, the fast respiratory tract panel, and the blood culture were all negative. The renal ultrasonography showed normal findings. Under the 3rd day of receiving antibiotics, we performed another urine analysis, also with the urinary catheter, and it showed us an unremarkable pyuria with a culture negative. So we discharged our patient from the hospital after 10 days of IV antibiotic therapy. Neonatal sepsis, as we know, has a wide variety of signs and symptoms, including every system. Our patient was a well-appearing newborn with fever, vomiting, tachypnea, and jaundice. The most common findings in neonatal sepsis are fever, respiratory distress, and tachycardia. Also, lethargy, poor feeding, bradycardia, apnea, poor perfusion, vomiting, or jaundice may appear. A rectal temperature of 38 centigrade Celsius or greater is regarded as fever in infants younger than 90 days. A temperature of 38 centigrade Celsius or greater by methods other than rectal measurement should also be regarded as fever, and the workup should be initiated. The main risk factor for developing neonatal fever in the first couple of days of life is dehydration. And the overall prevalence of serious bacterial infection is higher in the neonates. So that's why a full sepsis evaluation and the hospitalization for giving antibiotics are highly recommended. How do we manage a neonate with signs and symptoms of sepsis? First of all, we must do a prompt evaluation. And we must start an empiric antibiotic therapy. A full septic workup should be done, which includes a blood culture, a lumbar puncture, complete blood count, a chest X-ray if respiratory symptoms are present, a C-reactive protein or procalcitonin levels, and of course a urine culture. Is hospitalization necessary for all febrile neonates? Yes, it's necessary. Well-appearing febrile neonates also have considerable risk for invasive bacterial infection. After a complete sepsis evaluation, regardless of the initial evaluation results, well-appearing febrile neonates should receive empiric treatment with antibiotics, and they should be admitted to the hospital. And to understand the importance of urinary tract infections in neonates, we must know that it's usually associated with bacteremia and congenital anomalies of the kidneys and urinary tract. Among neonates and young infants who present with fever, the UTI rates vary from 7 to 15%. Neonates with UTI should be evaluated for associated systemic infections, anatomic or functional abnormalities of the kidneys and the urinary tract. And that's why we did a full septic workup and a renal ultrasonography to our patient. As we all know, Escherichia coli is the most common pathogen. In an abnormal ultrasound, the most common findings are usually pelviectasis and mild hydronephrosis. The tests we use to diagnose UTI in young infants younger than 60 days are leukostesterase, nitrite, and pyria. As we can see, the most specific test is nitrite, and the most sensitive one is the leukostesterase test. And how should we perform urine analysis? The urine should be obtained by either catheterization or suprapubic aspiration. The clean voided bag urine samples should not be used for culture, as there's a high rate of false positive results because of contamination. Urine specimens should be transported on ice, and they must be processed quickly to avoid further growth of organism in the urine specimen. And as a conclusion, urinary tract infections in neonates are more common in males than females. And there are no specific symptoms for UTI in neonates. A septic workup should be done to all patients who are diagnosed with urinary tract infections. And a renal ultrasonography also should be done to all neonates with urinary tract infections. And if we have an abnormal ultrasound findings or a non-E. coli pathogen, or the patient has recurrent UTI, we must perform a voiding cystoretrogram. And thank you for listening. If you have any questions, please don't hesitate to ask. Thank you.
Thank you very much for your nice presentation. I would like to ask a question from you, and that's this: for what you obtained PCR test from a baby what is firstly born and has fever. Is there any protocol, new protocol in your hospital or not?
No, you know, there is a COVID pandemic, so we should take some PCR for viral infections. But routinely, if you have upper respiratory tract infections or lower respiratory tract infections, we do PCR for viral infections. But due to pandemic, nowadays we take PCR test from neonates with fever.
Many thanks, dear Professor Can Polat. Would you go on panel discussion?
Okay. After finishing our case report, I would like to invite Professor Bayrakçı, and she is a pediatric nephrologist in our hospital. And I think she has some comments on the case. Yes, Professor Bayrakçı.
Good morning, dear colleagues. It's really exciting to meet friends from Tehran. Although Aslı covered the case, I'd like just to make some comments about urinary tract infection, how we handle cases. Our countries looks like similar about incidence of urinary tract infections and respiratory reflux. Thus, maybe we have almost the same protocols. Urinary tract infections are very important in the newborn period. It has a special importance because newborn are very delicate. They are prone to develop sepsis because of urinary tract infections. That's why the most important point that should be addressed here is maybe to make the diagnosis really quickly and to start therapy without any delay. It's quite common and risk factors, presentation, treatment of urinary tract infection, prognosis, all are different from older infants and children in newborn. Incidence in the first 3 days of life is as high as about 2% in developing countries. That's why we should be aware about urinary tract infections in febrile newborn. Children less than 2 months of age, if they have a febrile illness without any obvious source, then the incidence of urinary tract infections become as high as 20%. So we should be aware of the problem. The signs of the symptoms are also not obvious as older children's. That's why the most important thing is the clinician's suspicion. You should suspect about urinary tract infections and make tests to go to diagnosis. Familiar symptoms like dysuria, frequency, urgency, malodorous urine are not very recognized. Probably mostly absent in newborn. So you should suspect the disease. Full-term infants usually present with fever, followed by poor feeding, tachypnea, lethargy. But in preterm infants, mostly present with apnea, hypoxia, and tachypnea, and less commonly fever. Abdomen distension, diarrhea, vomiting, and failure to thrive also described in the literature. Neonatal jaundice is very important because probably it has some prognostic factors, and in literature we see that if a newborn presented with jaundice, 50% have a chance to have scars in the DMSA scan. So if prolonged jaundice is because of urinary tract infection, you should think that this might be something more important than we think. Like older counterparts, newborn also Escherichia coli is the most important, the most common microorganism, but Klebsiella and Enterococcus species are not very seldom. Especially group-based streptococci are not very, we are not used to see it in older children, but in newborn, it's possible to have infection with group-based streptococci. Diagnosis is very difficult because this is about the disease. American Pediatric Academics and many other consensus developed about how to treat.
Sorry, dear Professor Barakci, your sound is a little bit problematic.
Oh, I'm sorry, maybe because of the connection. Now?
It's better, I think, if you can start.
Okay. Although the definition is very obvious in all the children, it's difficult to get some.
Dear Professor, sorry, would you mind if I asking you using headphones or a headset?
Yes,
maybe it's better. Sorry, because your point is so useful and we don't want to miss it.
It's better?
It's well now, thanks.
Oh, nice.
Sorry for interrupting.
It's okay. It's not okay. So we don't have clear definitions of urinary tract infections in newborn. Although urine culture with more than 50,000 colony-forming unit in older counterparts are taught as diagnostic, in neonates we can use some other. Do you have a problem with noise again?
It's okay, Professor.
Okay.
Okay.
In neonates, because they vote frequently and it can lead to lower colony urine cultures. That's why maybe sometimes we can use 10,000 colony forming unit is enough to diagnose urinary tract infection. But every time you should correlate your findings with microscopic urine analysis. It is the most important point that I want to address here. Your urine analysis should correlate most of the time with your urine culture that's needed to rule out colonization or contamination from the laboratory. The easiest way, of course, to obtain the urine with bag, but it's not recommended because we have very, very high rate of false positive urine cultures. That's why usually we use urethral catheterization in newborn. Of course, suprapubic aspiration is the gold standard, but it is, as you know, very invasive, but its contamination rate is very, very low. So in also newborns with suspected of sepsis, we can use suprapubic aspiration. The most important thing to get appropriate urine sample, but that should not lead you to delay in the treatment. The most important thing is to start treatment as soon as possible. Because we know we have high incidence of sepsis if a patient had urinary tract infection, if a newborn had urinary tract infection. And every newborn with urinary tract infection should be evaluated for sepsis. And imaging when to do and who to do is the important question. Usually we in our country do urinary ultrasonography to every children, neonate or older or infant. We do ultrasound in the first urinary tract infection. It's not invasive, it is easy and it is easy to get in our country. That's why we recommend to every newborn to have ultrasonographic examination to rule out any dilatation, abscess, or calcinosis, or any congenital malformation. However, the question is to who we should do voiding ureterography. That is the question, because it is a little invasive and it has really a good dose of radiation, and we don't want to give it to every baby. That's why we should be more selective when we are deciding to do voiding ureterography and DMSA scans, but we recommend ultrasonography to every baby with a urinary tract infection. Ultrasound is not very sensitive to detect every vesicular reflux, but we know that if baby has a high-grade reflux, ultrasound is very sensitive. And that is the most problematic condition. If baby had high-grade reflux, they are prone to developing renal scars. That's why ultrasound should be used, but we shouldn't forget that if ultrasound is normal, that not mean that baby don't have vesicular reflux. If it is abnormal, it is important for us, but if it is normal, we should again think about voiding ureterogram later on during follow-up. Voiding ureterogram is gold standard for detecting vesicular reflux and posterior valve in boys. To whom we should do voiding ureterogram? Specifically, we should definitely do it to the patient with recurrent infection. We do it in our protocol if a baby had a second time urinary tract infection, then we get voiding ureterogram. If ultrasound reveals us urinary dilatation, anterior posterior valve dilatation, then we do voiding ureterogram. Treatment should be definitely parenteral, and every newborn always requires hospitalization for urinary tract infection. It's not recommended to treat in outpatient clinics because there's high incidence of bacteremia. If you have candida in its urinary culture, then please consult pediatric infectious specialist. Parenteral therapy should last minimum for 10 days, not less than 10 days. If baby's clinical condition is well, if it's more mature, then you can prefer to give therapy for 10 days or 7 days. Parenteral, then you can go with oral treatment, but patients should be hospitalized for 10 days, definitely. If you, the most important thing in urinary tract infection is because it can cause babies to get sepsis. And the second important thing for us is if a patient with urinary tract infection has vesicular reflux, this patient is a candidate future chronic renal insufficiency. That's why we need to know about vesicular reflux, to find it very early and to treat it very early, because we know somehow it is preventable and we can save our patients from developing chronic renal failure. That's why we want to emphasize vesicular reflux in our lectures with our students and residents. Treatment of vesicular reflux is not surgery. Surgery is required very, very rarely. Usually it resolves spontaneously when the patient comes to 6-year-old age. We usually recommend continuous antibiotic prophylaxis, although it is controversial and there is lack of evidence for the role of prophylaxis in neonatal population. We use prophylaxis in our patients if we find that they have vesicular reflux. And we usually prefer amoxicillin for 50 kilogram per day in one dose before falling asleep at night time until 4 or 5 months age. Then we pass to simethicone. It is very serious for neonates. It causes serious morbidity. Then prompt diagnosis and treatment should be initiated as soon as possible. That's the most important thing we should emphasize about this subject. If your patient have a tendency to develop recurrent urinary tract infection, please consider to do vesical voiding cystoretrogram to rule out presence of vesical reflux or posterior retroviral valve in boys. That's all I want to talk about. If you have some questions, I will be pleased to answer.
Thank you, Professor Bayrakçı. I think we have no time to take questions, and I try to guide through the website. So if you have further questions, I can answer through chat system. Thank you, Aylar.
Thanks a lot, dear Professor Bayrakçı, for your nice comments, and also dear Professor Can Polat for managing the panel. Professor Can Polat, can we have you for 3 or 4 minutes if you have any comments for the case, because in between your time panel, if you have any comments or any home taking points to add for the case for us, we will be so glad to hear that.
Thank you. This is a newborn infant with fever, and if you see any infants, neonates less than 2 months, we try to hospitalize these infants and exclude the sepsis evaluation. If we have a neonate with fever, we used to hospitalize in neonatal intensive care unit. So if any infant with fever less than 2 months should be evaluated with exclusion late onset sepsis. So thank you very much for all kind invitation, and thank you for Professor Bayrakçı for contributions. And I would like to answer through chat system if any further questions. Thank you very much.
Again, many thanks, dear Professor Can Polat, for accepting the invitation, and many thanks, dear Professor Bayrakçı, for accepting the invitation to joining the panel. We really enjoy your comments, your nice case, and many thanks for joining, sharing your knowledge with us. I wanna, between the panels, I wanna pass the microphone to my dear Professor, Dr. Ehsan Ağay, as the head manager of the AYMA, to welcome all of you again to the panel. Dear Professor Ağay.
Thank you very much, dear Aylar. I just want to thank our panelists, and especially Dr. Can Polat and the other friend from Turkey, and all the participants from our side and also from Turkey. And I wish for further collaborations with our friends there. AYMA is a new association here in Tehran that we have established recently, and we are open to all participants from all over the world, especially our neighboring countries, and more especially from Turkey. Thank you very much, and let's continue.
Thanks a lot. I just want to remind to please keep mute your microphones, and also if you have any question, ask in the chat section, so our dear professors and panelists will answer you as soon as possible. We are going to go with the second case. Also, please remain with us, stay with us, and also don't forget to keep your videos on at the end of the session to take memorial photo. We are going to go with the second case. I'm going to share the slides.
Hello, good morning, everyone.
I would like to give my honor to my dear professors and colleagues, especially from Ankara, and thank you all for accepting our invitation to the first International Morning Report. It's my pleasure to present our case. A 5-year-old girl, known case of ventricular septal defect, was brought to our hospital with chief complaint of retrosternal chest discomfort since 2 days ago. She was unable to describe the quality of the pain, and nothing seemed to worsen it. The pain didn't have any radiation, and it didn't get alleviated with rest. She had a prolonged low-grade fever since 8 days ago, and her told us that she had loss of appetite and non-significant weight loss in the course of last month. She didn't have nausea, vomiting, any gastrointestinal, genitourinary, or respiratory symptom. In her past medical history, she was born full term without any complications. She had a history of hospitalizations for 2 times. First in infancy because of icterus, when her neonatologist found a heart murmur. So echocardiography was done and it showed a small VSD. Since then, she had periodic follow-ups, and captopril was started for her since last year, which was discontinued with her cardiologist. Second, in 40 days because of pneumonia. Family history, non-consanguineous marriage without any history of diseases. Drug history, she didn't consume any antibiotics in the course of last month. In her physical examination, she was an alert and oriented child with pallor. Her lungs were clear to auscultation. She had normal heart sounds and normal heart rate and a holosystolic heart murmur. Her abdomen was soft, non-distended, non-tender, without any organomegaly. She had poor dental hygiene with no signs of infection. Other physical examinations findings were unremarkable. On admission date, she had a pulse rate of 120, a respiratory rate of 20 with 98% O2 saturation in room air, blood pressure of 165, and a temperature of 37.9 centigrades. Lab data, complete blood count and electrolytes were normal. CRP was 57, ESR was 84, urinary analysis was normal, blood culture was obtained the first day and it was negative. We requested an EKG and it showed just a sinus tachycardia. A chest X-ray was done and it showed a prominency of right lung umbilicus with no consolidation in favor of pneumonia. Now you can see the picture of the chest X-ray. Because of tachycardia and the past medical history of ventricular septal defect, a transthoracic echocardiography was obtained, which showed a 16 to 18 millimeter vegetation, which was attached to the anterior wall of right ventricle outlet. And it also showed a small perimembranous VSD. Now you are watching the movie of our echocardiography. In this picture, you can see the infective vegetation, which is located in the right ventricular outlet tract. Due to spread of infectious vegetation to the pulmonary artery, we performed HRCT, which showed septic emboli events.
Can I speak?
Sorry, Dr. Zamani, we will be with you in the end of the session.
Just in a moment. Just in a moment, we will be with you, Dr. Zamani.
Okay. Okay, so we categorized our differential diagnosis into three main categories. First, infectious diseases such as pneumonia, urinary tract infections, endocarditis, myocarditis, and COVID-19, malignancies such as leukemia and lymphoma, and autoimmune diseases such as rheumatoid arthritis. In summary, a 5-year-old girl with past medical history of ventricular septal defect was brought to our hospital with chief complaint of retrosternal chest discomfort, a prolonged low-grade fever, loss of appetite, and non-significant weight loss. On her physical examination, she had tachycardia and a holesystotic heart murmur. So we admitted her to our cardiology ward with impression of infective endocarditis. We started IV antibiotics to her, including ceftriaxone, vancomycin, and rifampin, with a total duration plan of 4 weeks. We repeated a transthoracic echocardiography for 3 times, which showed stable size vegetation and normal cardiac function. In consultation with our surgeons, cardiologists, and pulmonologists, we planned a surgery on her to close the VSC and remove the vegetation. Thanks for listening with patience. Many thanks to dear Dr. Babai for nice case presentation. And thanks participants for listening. Dear Dr. Zamani, pediatrician and radiologist, are you with us, dear professor?
Yes, I am.
Thanks a lot. Thanks for joining us. Dear Professor Zamani, could you please help us with the chest CT scan, please?
Hello, dear eminent professors and assistant. Good morning. I do welcome to Turkish community and novel morning report. If you show my
Here you are, Professor.
Oh, thank you. In the chest CT, we see a airspace consolidation, apico-posterior segment of right upper lobe. Yes, in this area, in this cut. Okay. And can you roll to the down?
Sorry, dear professor, I think the video has a problem. I will replay for you. I think the problem is with the net for uploading the video. You Please continue. I try to replay the video.
Okay. Okay, this cut is good. Here now we see two small variable size nodules in the nodule in peripheral of the lower lungs bilaterally that we have seen pre-regional haziness in the left side nodule in the left lower lung, and that there is no evidence here. And we see a vascular pedicle that has entered to the nodule. That is a vessel sign that we see in the septic emboli. And there was not any pleural effusion or hilar adenopathy. According to patient's history and have a endocarditis history, and we see peripheral different size nodules in the mostly in lower lobes, and that has a vessel sign which suggested a septic emboli. And I only can say the nodal densities could be in different stages of cavitation. We know we don't see any cavitation in this city now, which could be due to early diagnosis. And nodal size could be between 1 to 3 milliliter, 3 any pleural effusion in this chest CT for this patient. If any questions, I do welcome to them.
Many thanks, dear Professor Zamani. I'm again sorry for the problem with the video that I think it could relate to the internet speed. Many thanks. Next, we are going to be with dear Professor Dr. Majnoon, a pediatrics cardiologist. Dear Dr. Majnoon, are you with us?
Yes, good morning. Yes, good morning. Thank you for letting me share my case. This 5-year-old girl yes. Good morning again. Thank you for letting me share my case. This 5-year-old girl went to hospital with a history of PMVSD with some symptoms and signs of chest pain, fever, and malaise. And in echo, which was performed with one of my colleagues, endocarditis was discovered and was referred to us. As mentioned, blood cultures was negative, but there was a highly mobile vegetation attached to pulmonary valve, and we admitted the case, and because of low hemoglobin, we transfused Paxil, and we put the patient under 3 antibiotics because of negative blood cultures. We continued antibiotics with the 3 antibiotics. And I would like to mention that in these cases, like this case, endocarditis happens in virtually in all cases who have pressure gradients in their heart, and like this case, which had a VSD with a pressure gradient of 57 millimeter Hg, and usually what happens is a non-bacterial thrombotic endocarditis happens at first because of endothelial damage, and because of transient bacteremia, adherence of bacteria to this NBT happens, and proliferation of bacteria within the vegetation happens. And for our case, we had criteria, although the blood culture was negative, but we had two criteria. Echocardiography was supporting endocarditis as a major criteria it took, and as a minor criteria, we had predisposing heart condition, VSD, fever, which was more than 38, and vascular phenomenon, which was pulmonary emboli, and immune phenomenon, which was RF positive. So we had two criteria, one major and four minor criteria supporting endocarditis. So we continued antibiotics, and we decided with our colleagues, because of multiple embolies of the lung, to do the surgery because the mass was highly mobile, and we thought that it may happen multiple embolies again. So we did the surgery, asked our colleague Professor Radmer to do the surgery, and finally surgery happened. Fortunately, very good surgery was performed, and the patient is good and healthy now. We continue antibiotics, I think, for 6 weeks, and we follow this. And the matter that I should underline here is for a case like this with VSD, good oral hygiene may be the best way to reducing the risk of endocarditis in cases like VSDs, PDAs, and other cardiac conditions that may endocarditis happen. And the other matter that in my case may be important is that blood culture was negative. And in right-sided endocarditis, blood culture may happen to be negative because of filtering effect of the lung, as it happened in my case. Thank you.
Many thanks, dear Professor Majnoon, for joining us and giving us this valuable knowledge and the points, taking home points. Again, thanks a lot. And we are going to be with Professor Mohammad Reza Modarresi, Pediatrics pulmonologist. Dear Professor Modarresi, are you with us? We will be glad to have your comments on the case.
Yes, I'm here. You.
Good morning, dear Professor.
Hello, Dr. Modarresi, and just please consider the time, and please do your lecture only in 3 minutes. Thank you very much.
Thanks a lot.
Thank you. Okay, I'm hearing you, please. Good morning, everyone. Is there any question about this patient?
Yes, please tell us, what are the symptoms of pulmonary emboli? How can we manage a septic emboli that is refractory to antibiotics? And does the surgical treatment has a place in your opinion or not?
Yes, good morning again. It's the pulmonary emboli, in contrast to adults, unlike in adults, in pediatric pulmonary emboli, often appear clinically silent. And but the classic symptom with these patients are increased shortness of breathing, pleuritic chest pain, such as our patient, hemoptysis and cough, and also syncope in the advanced cases. So the presentation of the patient with pulmonary emboli in pediatric, especially in pediatric, is not the same as adult. And so the diagnosis of this patient will be dry in compared to adult. But for your second question, what is the treatment or management of pediatric septic emboli? The best choice or the first line of treatment for this patient are antibiotic therapy. Empirical antibiotic therapy. The second step is about the anticoagulant therapy. Anticoagulant therapy is not recommended for this patient because there are some complications such as bleeding in the brain and other parts of the body. So the anticoagulant has not a good role for this patient. Septic emboli, no pulmonary emboli, routine or usual pulmonary emboli. About the third question, the first approach for this patient is antibiotic. And another choice is the intensive care management for this patient. But about the surgery, there is a limited data for surgery for these patients. But in some situations, the best treatment in surgery and remove the emboli. If the patient doesn't respond to our treatment, especially to empirical antibiotic treatment, we can choose the surgery and the massive emboli in the lung, in the pulmonary artery. So the first choice is antibiotic, but if the patient has a large pulmonary emboli and the patient refractory to our treatment, the second step is surgery. Okay.
Thanks a lot, dear Professor Modarresi. Very nice points. Thanks a lot for joining us and giving us your time again. As a last panelist, we are going to be with dear Dr. Abdolsalehi, the infectious disease specialist. Dear Professor Abdolsalehi, are you with us? If yes, I'm going to ask a question.
Yes, okay. Thanks a lot. Good morning. Hi, everybody. After performing the initial evaluation of a patient with suspected infective endocarditis, the physician must make a clinical judgment about when to initiate a therapy. If the findings are strongly indicative of the diagnosis of the child is very ill, treatment should be started as soon as blood has been drawn for culture. Initial empiric therapy depends on a clinical setting in which the tentative diagnosis is made. If the infection is subacute, a combination of penicillin G and aminoglycoside usually is recommended for its activity against viridans, streptococcus, enterococcus, or most gram-negative bacteria. If Staph aureus endocarditis is a strong consideration, vancomycin and a penicillinase penicillin should be added to regimen. Treatment of culture-negative endocarditis is problematic. So our patient was admitted in a heart ward in a children medical center. Treatment of culture-negative endocarditis, the suggested regimens for treating culture in a children in the AHE 2050 pediatric guideline, including the native valve, ampicillin sulbactams plus gentamicin plus ciprofloxacin. If the prosthetic valve, vancomycin plus gentamicin or cefepime plus rifampin. Parenteral administration of antibiotic is preferred because erratic absorption of oral antibiotics. The AH of Pediatric Endocarditis Treatment Guideline states the home parenteral therapy can be considered after in the hospital in selected patients who are stable, febrile, afebrile, have a negative blood culture, and are at a low risk for a complication, not fungal endocarditis or young age. A proline treatment, usually a 4 to 6 week or longer, is necessary. According to pediatric infections references, the VSD do not have the ability to prophylaxis with antibiotics. a completely accepted medical practice has been to give prophylactic antibiotics to susceptible patients in an attempt to prevent infective endocarditis. Thank you for attention.
Many thanks, dear Professor Abdul Salehi, for accepting our invitation to be our panelist, and thanks a lot for sharing this nice scientific points. Dear all, again, thanks for participating. I want to kindly ask dear Professor Bad, the head of Children's Medical Center and also the honorary member of AYMA, to join us for some minutes and share points with us. Dear Professor Bad, we are with you.
Thank you so much and good morning, dear friends in Turkey and Iran. Thank you so much for your warm and kind participation, and hope to have more and more collaborative, amazing programs such this together, and wish you all safe and COVID-free coming days. Thank you so much for having me, and thanks a lot for this program. Thank you so much.
Thanks a lot, dear Professor Badvan. Also, I want to thank you from all AYMA members to support us and to give us the chance to having this session, dear Professor Bad. Everyone, thanks a lot for participating, especially Professor Bayrakti and Professor John Pollard and dear Dr. Asli Gent. If you remember, we want to have a memorial photo, so please keep your videos on. I want to again thanks for everyone to participate in this session. We wish to see you in further and more joyful sessions like this, especially with the Ankara and Turkey, that they are the good friends of us. Also, I want to remind that we want to upload the complete video of this session on YouTube and also on the AYMA's website. You can follow this. Let's have the memorial photo, the executive committee, please.
Okay, everyone, so please open your videos. Let me see your beautiful smiles in this morning after this amazing morning report. Okay, oh my God. You have to give me a few minutes, okay? So keep smiling, keep saying COVID, COVID.
I think the most beautiful picture will be from Dr. Asli and Professor John Pollard. That is a very, very nice.
Oh my God, yes.
I wish we can meet you in person very soon in Tehran, and we can host you here in person.
Thank you. We hope so to see you in Tehran also.
Okay, so
we'll see you soon.
One last photo. Okay, so just for 1 minute, okay? Keep smiling for 1 minute because there's a lot of participants. I have to take photo of everyone because everyone will be nagging at me after that, okay? So keep smiling.
Meanwhile, I should thank again the head of the Children's Medical Center, Dr. Bad, and also the deputy of education here, the Professor Movahedi, for helping us with this session. And soon we will have our Nowruz. I should say Happy Nowruz to everyone that celebrate Nowruz. And after that, after the holidays, Nowruz holidays, we will have our next session that will be amazing too. And you are most welcome to our other sessions that will be regularly happens from now on. Thank you very much. Aylar?
Many thanks, dear Dr. Bakhtiari, for taking these memorial photos, and also dear Professor Aghaei for sharing this nice word with us. Everyone, thanks a lot for giving us your time. I wish all of you very, very good day and very, very good week in front. Thanks a lot. Take care. See you soon.